Hi, this is Steve Treon. I was given the opportunity today to be able to have this presentation on the NCCN guidelines in Waldenstrom's macroglobulinemia by the International Waldenstrom's Macroglobulinemia Foundation. I'm actually excited about this presentation because ultimately, all the research that we do, basic science, translational science, even clinical trials, comes to meaning when we're able to actually see the drugs and approaches to therapy for Waldenstrom's that actually make it to the NCCN guidelines. And perhaps many in this audience might not be familiar with what exactly the NCCN means. And so I'm hoping in the next hour to be able to acquaint you with the NCCN, but also give you insights into how the guidelines were developed. Now, the NCCN is very important because ultimately insurers, as well as Medicare itself, bases decisions around reimbursement on drugs based on NCCN guidance. And this is why this is such an important topic. And I'm really happy that the IWMF included this topic for discussion today. So let's get going here and have the opportunity to be able to present all the exciting data involving the NCCN, and very importantly, to give you a glimpse into the inner workings of how the NCCN works. So I'm going to actually review both the guidelines for lymphoplasmacytic lymphoma, which actually is a pathological term for Waldenstrom's macroglobulinemia, as well as IgM-MGUS, which you know is a precursor condition, and IgM-related disorders, which I'll talk to you a little bit about to give you some insight as to what that term actually means. So NCCN stands for National Comprehensive Cancer Network. There are 34 institutions that make up the NCCN. They're shown here. And what the NCCN is, it's a group of distinguished cancer centers, and you can see they're from all over the United States, that have representation on different committees that deal with different cancers. And when new drugs or approaches come to be in a particular cancer, members representing these NCCN institutions actually get together and they vote. They vote in a very open way, after a lot of discussion and deliberation as to whether or not to allow a certain approach or drugs to be incorporated into these guidelines. So I'm going to start off by acquainting you with these guidelines to actually talk about the diagnostic criteria for Waldenstrom's based on NCCN guidance. And this is actually very important because it establishes who really has Waldenstrom's based on this guidance. And both the WHO, the World Health Organization, have a committee that actually deliberates on this, but so did the International Waldenstrom's Macroglobulinemia Workshop. And as a result, you actually see these criteria being incorporated into the NCCN. This is very common to actually adopt criteria from established organizations like the WHO and the Waldenstrom's Macroglobulinemia Workshop group. And so at the end of the day, what is Waldenstrom's? Well, it's if you have the diagnosis of lymphoplasmacytic lymphoma based on the WHO criteria, and this involves having the bone marrow infiltrated with small lymphocytes, these lymphoplasmacytic cells, which look a little bit like mature plasma cells, but have some of the features of earlier lymphocytes and plasma cells. And these may be terms that may not be important to you, but it's important to recognize that when you have Waldenstrom's, there are different cell populations. They're all related, different cell populations within the bone marrow. And the pattern, as well as the expression of certain targets on the tumor cells themselves, also factor in to the actual diagnosis of Waldenstrom's. Now, the thing to remember is that based on this guidance, just having an infiltration of the bone marrow and having an IgM of any concentration level makes the diagnosis of Waldenstrom's macroglobulinemia. Now, the NCCN also provides guidance on how to work up somebody that's suspected of having Waldenstrom's macroglobulinemia. And there are two criteria here. One that's essential, which means get all these tests done in somebody that you suspect has Waldenstrom's. And then there's also useful in certain circumstances, which gives guidance again to the doctors based on what they're encountering for symptoms or presentation of a particular patient, into understanding what they should do at minimum as part of the workup. And you'll see that things like, the history of the patient's presentation, physical exam, various blood tests, bone marrow, all factor in here. Getting a CAT scan of the chest, abdomen, and pelvis factor in here. And also molecular testing is now part of this. And in particular for MYD88, looking for the MYD88 L265P mutation, which we'll talk about, very shortly, using PCR. You're probably all familiar with PCR now because of COVID testing, but this is the approach that's advocated here. And then under certain circumstances, where patients may present, for instance, with symptoms of hyperviscosity, they may have certain underlying symptoms like neuropathy. They may be, experiencing in cold conditions what we call Raynaud-like phenomenon. They may be having CNS, central nervous system symptoms, confusion, let's say, or having some sort of neurological deficit. You see that these are also, incorporated into these guidelines where under these circumstances, when a patient actually presents, additional workup is warranted. And here too, I just want to call your attention where the arrow is that the CXCR4 mutation testing also is advocated here, particularly for people that are being considered for a BTK inhibitor, in this case, ibrutinib. So it just gives you some idea as to how NCCN has also thought through the workup of a person who's being suspected of having Waldenstrom's. Now, to be able to acquaint you with why the molecular testing is incorporated, I think it is important to give you some background. In our laboratory, back now almost 10 years ago, the genetic mutation in MYD88 was discovered. This was discovered, and I want to just emphasize that the IWMF played a pivotal role in providing funding, as also did Dr. Peter Bing, for which the Bing Center at our institution is named after. And this was no small feat because in its day, whole genome sequencing was still a very nascent art, but it did lead to the identification of this mutation, the L265P mutation. Now you may say, what does that mean? Well, it means that the amino acid leucine at position 265 in the amino acid sequence got switched over to proline. And that's actually substantial because proline distorts very much the protein and in this case gave it new function, which we'll talk about. But 91% of the patients actually had this mutation. Of course, this was big news since we didn't know what caused Waldenstrom's, and it made the New England Journal of Medicine. And subsequently, a number of other laboratories using other techniques, including PCR or different types of sequencing like Sanger sequencing or whole exome sequencing, were able to validate these findings. And these are just a small handful. I mean, there's probably in the order of about 60 papers now that have been published on MYD88 that actually followed this very pivotal discovery. And you can see these were laboratories from all over the world. And it was interesting because if you look at the column under WM, what you see, in fact, is that the range of who's MYD88 positive, MYD88 mutation positive, ranges quite a bit. For most studies, it was somewhere in the range of about 85 to 95%. But you see there are differences depending on the testing technique and whether or not the bone marrow actually was selected out and you took out the Waldenstrom cells and tested for that. I also want to call your attention to the column under IgM-MGUS. This is monoclonal gammopathy of unknown significance. This is a precursor condition to Waldenstrom's. It was first described by Bob Kyle. And you'll see there that, a lot of these patients are in fact positive, depending on the testing technique, whether it's much more sensitive, you can see quite a bit of range. And I think these days, most of us believe that somewhere between half to about 90% of patients actually have the mutation in MYD88. So it occurs even in the precursor state of IgM-MGUS. Now, why is this mutation important? Well, there are a lot of reasons, but the one I want to call your attention to is the fact that it can help us separate Waldenstrom's from other diseases that also secrete IgM. After all, IgM is very much an important part of the Waldenstrom's diagnosis. And this is PCR testing. Again, I think you're all familiar with PCR by now. You've probably been COVID tested by PCR already. And what you do here is you actually use a machine that cycles to pick up the MYD88 mutant form. This is usually done by taking out the B cells from the bone marrow and examining them, although many now use PCR directly on the bone marrow that's extracted without actually separating out the B cells. And there's also data now to show that even in peripheral blood, you can take out cells and test for MYD88. But you can see here in this beautiful work that was done by Lian Zhu, who established the first PCR for MYD88 and published this in the journal Blood back in 2013, that she achieved something that was very exciting. She showed that Waldenstrom patients, when the cycler went on, very low levels of cycling detected the MYD88 mutation in Waldenstrom's. But you see other diseases here like marginal zone, IgM myeloma. These had very few positive to no positive patients. CLL, there was one here among many. Almost all of them were negative. Among MGUS patients, IgM MGUS patients, about half of them, slightly more than half, were actually positive. And the ones actually that were super positive turned out, very soon thereafter to become Waldenstrom's patients. And so she was able to establish this technique with a particular cutoff in mind to show who was positive and negative for MYD88. Now, the importance that I alluded to of detecting MYD88, even among IgM MGUS patients, was also highlighted in this beautiful, series of studies by Marzia Baratoni from Italy and Cristina Jimenez from Spain, as well as Lian Zhu. And what these studies collectively have alluded to is the fact that if you have the precursor condition IgM MGUS, and you also have the MYD88 mutation that's detected, you're more likely to become a Waldenstrom patient in time. It may take a while because IgM MGUS patients don't, convert very, very quickly. It takes time sometimes, but the stronger the signal in the presence of the MYD88 mutation do in fact forecast for this conversion. Now, this is a very interesting study that came from Spain, and it showed that among unclassified people with different B-cell lymphomas, that when the MYD88 status of a patient was factored in almost all of these cases, the conversion from a still unclear diagnosis or even a different diagnosis was revised to Waldenstrom's. And again, you'll see LPL here. But what LPL here means is lymphoplasmacytic lymphoma, which is the pathological diagnosis, underlying diagnosis for Waldenstrom's macroglobulinemia. Now, MYD88 can also help us separate out, as I alluded to, Waldenstrom's from other B-cell malignancies. But keep in mind that some of these other malignancies can be bad actors if the MYD88 mutation is not there. You do want to work these patients up. Because they may have a different type of lymphoma or other B-cell disease. In this case, the one you don't want to miss is IgM myeloma. And patients that have super high levels of IgM, in this case, on average 8,000, when they did not have the MYD88 mutation, some of these patients actually had IgM myeloma. This is from a paper that I published in the British Journal of Hematology a few years ago. And so there is additional testing that can be done to help sort out these patients. And it is very important, that clinicians keep this in mind. Now, MYD88 testing also can be very important. This is part of the NCCN guidance. If you're suspecting that somebody has Waldenstrom's disease that made it into the brain, or perhaps, got into the lung and is now causing effusions. This is collection of fluid that occurs in the lung space. And these very exciting studies by Dr. Stephanie Poulain in France, as well as Dr. Josh Gustine in our laboratory in Boston, alluded to the fact that you can use MYD88 testing to actually make these diagnoses, because there are other things, of course, that can cause symptoms in the brain as well as collection of fluid in the lung. And so this is now part of the NCCN guidance. Now, those patients that actually have the MYD88 mutation tend to fare better, despite whether they have the CXCR4 mutation or not, compared to those that do not have the MYD88 mutation and are legitimately Waldenström patients based on, their underlying pathology. And this is because these patients tend to have a high risk of transforming to aggressive lymphomas. And that's why also knowing the MYD88 status of somebody might help you predict this. And there are particular reasons, on top of these survival differences, that you also want to keep this in mind, because the patients that don't have the MYD88 mutation often don't respond as well to ibrutinib. They tend to progress sooner. And you see, in fact, that the mutations that these patients have tend to be very different. And they are overlapping many times with aggressive lymphomas. And that's why I think it is important, as years go ahead, that we better, we really need to have a better sense of what these other mutations are that are driving the disease. We know some of them that have been alluded to from Zach Hunter's work in our group. But this will also give us, I think, in the long run, the opportunity to innovate new therapy. Now, keep in mind that other diseases, have similar types of dilemma. And we see across the board that other drugs, even in Waldenström's, you've heard about ibrutinib, you're going to hear a little bit more by me and others about zanubrutinib, can also show differences based on the genomics. And in the case of ibrutinib, we're going to talk about the fact that if you have the MYD88 mutation alone, you tend to have better responses to ibrutinib. If you have both the MYD88 and CXCR4 mutation, you still respond very nicely, but the depth of response isn't as high and it takes longer. And we do know now with zanubrutinib data that those individuals that actually do not have the MYD88 mutation tend to respond to zanubrutinib, whereas we don't see as much activity with ibrutinib. So the genomics are going to also help us in the long run to be able to make informed decisions around how we're going to treat Waldenström patients. Now, one small footnote, which I think is very important, it comes up at all our pathology meetings as well, is that despite the fact that patients with Waldenström who do not have the MYD88 mutation, these are not people that actually have a different disease. It's really important to keep that in mind. And I think this really, works back to the work by Zach Hunter in our group, because not only did he identify the mutations that underlie the patients that don't have the MYD88 mutation that actually make their Waldenströms grow and survive, but he also made an interesting observation, and that is when he looked at the expression patterns of genes in these patients, they overlapped even with the people that did have the MYD88 mutation. That's why I think these are really not two different diseases, but variants of each other, that their underlying mutations generate different characteristics, including to drug response that we just alluded to. Now, here's a big problem that I want to share with you, and that is being able to detect MYD88 largely depends on the testing being used. Classically, we've used PCR. When the bone marrow was extracted, we used PCR to be able to find the MYD88 mutation. But in the clinical setting, many times next generation sequencing, or what we call NGS, is used. And so when you look at different clinical trials, you see that the percentage of people that actually have the MYD88 mutation can differ. And many times this difference is based upon what technique they used. So two very capable investigators in our group, Amanda Kofides and Josh Gustine, did a very nice series of comparison studies. The one that got published here this year compared same patients who were tested for MYD88 by next generation sequencing and those that were tested by PCR. And what they found was that in 1 in 3 Waldenström patients who truly had the MYD88 mutation, they were actually missed by NGS. And this was more likely, as you can see here, to be those patients that had lower bone marrow involvement. And so particularly those that had less than 20% of their bone marrow involved with Waldenstrom's. So you do see here that many times the MYD88 mutation can be missed depending on the technique. And that's why in the NCCN guidance, you see that PCR testing is advocated for doing the initial workup of somebody suspected of Waldenstrom's. Now, I want to next talk about CXCR4. I did mention to you already that the CXCR4 mutation can be useful under certain circumstances. I want to give you at least a background. This was also a mutation discovered in our laboratory thanks to whole genome sequencing. The effort was led by Zach Hunter, and this was published as a plenary paper in Blood in 2013. And up to 40% of patients with Waldenstrom's actually can have this mutation. It's more likely to have this mutation if you have also the MYD88 mutation. And let me just explain to you that this is a mutation that's found in what we call the C-terminal domain. Now, this may not mean very much to you if you're not a biochemist or a genomics person, but this is the little pigtail that exists within the cell itself for this molecule. CXCR4 is a receptor. It's found on the surface of cells. And it's an important receptor because it signals for this molecule called CXCL12 that's made by the bone marrow. And as a result, when CXCL12 comes in contact with its receptor, a lot of things happen, including the fact that Waldenstrom's cells can then migrate towards the bone marrow. And that's one of the reasons why we believe you see patients with bone marrow involvement predominating with this type of lymphoma. Now, there are two flavors of CXCR4 mutations, which I want to acquaint you with. So far, actually, over 40 different types have been described. Half of them are what we call nonsense. Nonsense mutations occur when the genetic alteration that's been made has introduced a stop codon. Stop codons, are breaks, and you don't see the DNA anymore coding for protein. And as a result, that little pigtail at the end gets lobbed off. And the most common nonsense mutation is this S338X. Again, to acquaint you with nomenclature, S is serine, which is an amino acid. And at position 338, a stop codon was introduced. And that's why we use the term X. And after that, the protein got lobbed off. Now, in the other case, frameshift mutations, which make up about half of all CXCR4 mutations, you actually are scrambling the code by either deleting or inserting DNA. And as a result, the readout of that protein becomes quite, gibberish. And depending on which type of these mutations you have, makes a big difference. In fact, it's the patients that have those nonsense mutations, the S338X, that are going to come in with very high IgM levels, a lot of bone marrow involvement. They're going to be the ones that have the hyperviscosity crisis. They're also the ones that are going to be less sensitive to BTK inhibitors. And in fact, there was this beautiful work just recently published by Dr. Wang and colleagues at MD Anderson. And what they actually found was that if you had the nonsense variant, that your time to needing treatment was much sooner. And overall survival was also adversely impacted by having one of these mutations. And so keep in mind that drug therapy has now evolved, but nonetheless, these mutations can be very important in terms of forecasting outcome in Waldenstrom patients. Now, another very important lesson. These were actually learned at our institution, thanks to the work of Dr. Yang Kao in our laboratory and Dr. Aldo Recaro and Dr. Irene Gobriel's laboratory. What we learned was that the CXCL12 from the bone marrow stroma bound to CXCR4, when you had the mutation in CXCR4, there was a continuous signaling effort that was introduced. And normally when a protein binds to a receptor, you get signaling for a very short period of time, and then it fizzles out. But if you have the mutation in that pigtail, you can't really shut down this apparatus. And as a result, you have ongoing signaling. And what we learned from our collective studies was this can contribute to drug resistance, which was why it was very important when we did the pivotal trial for ibrutinib. This was a trial that actually led to the approval of ibrutinib in Waldenstrom's macroglobulinemia, that we wanted to see what the impact of the underlying mutations were. And you can see here by comparing the patients that only had the MYD88 mutation and were CXCR4 WT, that means wild type, meaning no mutation is present there, compared to the patients that were double mutated, that had mutations in both MYD88 and CXCR4, you see that the depth of response, the attainment of, let's say, the major responses, which is at least a 50% reduction in IgM, and more importantly, VGPR, very good partial response, more than a 90% decline in IgM, was far, far less. In fact, the difference was quite astounding here. VGPRs were attained in 47% of patients only with the MYD88 mutation, but only 9% for those that were double mutated. And it also took longer, almost 3 months longer, to be able to get to a major response. And so you see once again why understanding somebody's MYD88 and CXCR4 mutation status are important. And this is why I think this is genuinely an important consideration and was introduced into the NCCN guidelines. And on top of this, what we also learned was that ibrutinib, by itself, very active drug. In fact, at 5 years, 54% of the patients still did not progress, and 87% were alive, even though these were heavily pretreated patients. But you see on the right side that the actual mutation status made a big difference in terms of who stayed in a remission and who progressed. And so it is important, once again, to understand why the genomics become part of this workup. Now, the INNOVATE study also taught us a very similar lesson. This was a very big study that occurred at 45 centers in 9 countries. Can you imagine that for Waldenstrom's? And 150 patients were randomized to either get ibrutinib and Rituxan or get placebo and Rituxan. And what did we learn here? We learned once again the genomics made a difference, and the CXCR4 mutated patients were the individuals that were more likely to progress. Now, surprise here for us was the fact that those that did not have the MYD88 mutation actually did as well as they did. But I think here too, keep in mind that next generation sequencing was used to determine somebody's MYD88 status, and I suspect that many of these patients were in fact MYD88 mutated. And you can see here this big drop very early on in progression, in progression-free survival, probably represents the true MYD88 wild-type patients. Now, this is a beautiful collection of studies done by Dr. Jorge Castillo in our group and Dr. Josh Gustine. And they also alluded to the fact with ibrutinib that if you had the nonsense variant, with Waldenstrom's, and you were treated with ibrutinib, that you were more likely to progress. And Dr. Gustine went one step further, because CXCR4 is not a mutation that you find in every Waldenstrom cell in somebody who has the MYD88 mutation. Only a small fraction in some cases, the average is about 30%, actually have the mutation. But despite the fact that only a fraction have the mutation, the more of that fraction that actually contained the mutation, the more likely it was to actually progress on ibrutinib. So it's not just having the nonsense variant, but the percentage of the cells that actually carry the nonsense variant that are both variables. Now, we also learned from the ASPEN trial, which I'll talk to you about momentarily. This is the trial where zanubrutinib was pitted against ibrutinib, that it did make a difference. Once again, the depth of response, whether you had the MYD88 mutation and also CXCR4. There were fewer patients that made VGPRs, very good partial responses, if CXCR4 was present. This was true in both zanubrutinib and ibrutinib treated patients. You can see right down here that if you had no CXCR4 mutation, just the MYD88 mutation, 34% responded. But if you had also the CXCR4 mutation, 18% of the patients got to a VGPR among zanubrutinib treated patients. And among ibrutinib treated patients, much the same. You saw this difference. And so it does show us that CXCR4 mutation status does also impact not only ibrutinib, which we knew about, but zanubrutinib as well. So again, how you test for CXCR4 is a challenge. And in fact, in many of these trials, you'll see different CXCR4 numbers being flaunted. And this is because, again, different testing techniques. If you use next generation sequencing, as we did in this study here by Dr. Josh Gustine, was published this year actually in the journal, British Journal of Hematology, that 2 out of 3 patients were actually missed for having a CXCR4 mutation compared to a much more intricate introspection using PCR and Sanger sequencing. And this was, again, more likely to be the case if you had somebody who had, lower bone marrow involvement. The false negative rate, as you can see here, was astonishingly higher if the patient had, under 20% involvement, particularly under 10% involvement. So keep in mind, as you go about, getting worked up, that the type of testing that is used makes a difference. And unfortunately, because there are over 40 different types of CXCR4 mutations, next generation sequencing is a must. It's very hard to work up patients by combinations of other techniques. But there is some light at the end of the tunnel. This was a beautiful paper that came out this year from the MD Anderson, again by Dr. Wang, where they actually used a slightly more enhanced next generation sequencing technique, which they use bidirectional paired ended sequencing. And they also use what we call molecular barcoding. I know that this from almost all of you will be gibberish, but it does show you that if you can enhance the technique of NGS, you can actually increase the detection of CXCR4. And in this case, I just want you to look here at the bottom, that in this case, they detected CXCR4 mutations in almost 40% of patients. And so it does show you that we can up our game for CXCR4 testing as well, and we will in due time. Now, also to keep in mind that the way we're testing for these mutations is probably going to evolve in due time. There are now a number of papers using cell-free DNA analysis. If you're not familiar, you're going to be excited to know that you can actually take somebody's blood, you can actually take somebody's plasma from the blood, and you can actually test for these mutations. And in fact, you can get very high sensitivity for both the MYD88L265P mutation and also the nonsense CXCR4 mutation that I think we care about the most, now seeing the collection of all the data that's been produced. And so, it might be possible in the near future that, merely that the need for bone marrow biopsies just to establish somebody's molecular background will not be necessary. And it may be necessary if, in fact, the answer is, negative and you want to work it up even further. But look at the sensitivity here by NGS. It was actually quite high. It was 80% for the MYD88L265P mutation and 67% for the nonsense variant S338X. So again, I think we're going to get smarter, and it's going to get easier to make these calls and not need a bone marrow biopsy. Now, I'm going to enter into the realm of talking about treatment approaches that are advocated by the NCCN. And again, the way these get on the NCCN guidelines is by, voting of all the member institutions. And you should also be aware of the fact that the recommendations get a priority score. You can see Category 1, Category 2A, Category 2B, Category 3. And let me just acquaint you with these terms. Category 1 studies that support, the inclusion of a recommendation are typically large randomized studies. This is where you either randomize against a placebo or you randomize against another established therapy, more likely the latter. And so these get the highest level of support. Category 2 studies are generally supported by prospective, meaning that it's a planned out study with good, follow through. These are usually phase 2 studies, so they're single arm. There's no randomization or comparison. And usually the ones that make the 2A recommendation are larger multi-center studies that have had a number of studies that have confirmed the findings. And so these usually make the 2A recommendations. The Category 3 recommendations are based on any level of evidence. Usually these are small patient series or retrospective data analyses. So they are the weakest of all the recommendations. And this is important because doctors want to know the strength of the data that supports a particular recommendation. So I'm going to talk about now the Frontline recommendations by NCCN for Waldenstrom's. This is for newly diagnosed patients who are symptomatic and require therapy. And you'll see right off the bat that there are, two divisions here. Preferred regimens, which means that based on the evidence at hand, that these would be the preferable treatment approaches. And then there are other recommended regimens that are also included here. And again, this is sized up by data as well as balances of efficacy and safety. So you'll see in the preferred regimens that the use of bendamustine and rituximab is one, bortezomib, dexamethasone, and rituximab is included. You'll see that rituximab, cyclophosphamide, and dexamethasone is included. And these are category 2. And ibrutinib, either alone or with rituximab, or zanubrutinib by itself, actually made category 1. So this is, again, the highest level of evidence supporting their inclusion in this preferred regimens group. Now, mind you, these are listed here alphabetically, not by priority. This is not to say that any one of these approaches is recommended by NCCN. What it does show you here is that these are the preferred regimens, but this also exposes some of the weakness of the NCCN, which is that you don't really get guidance as to which of these regimens you should use. So it's much like going to a restaurant and you see what the specials are for the day, but then it's up to you, in this case, the clinician and the patient, working together to establish what might be the appropriate therapy. Now, this is still very important because it does give clinicians, an understanding of what are the current and recommended therapies to be used. But as I said, the holdback here is that it doesn't tell you exactly what to do. And that's because I think Waldenstrom patients present very differently. And this sort of, approach to actually figuring out which therapy is needed really needs to be individualized. And that's what the NCCN really wants to do. On the other hand, what this also does is it allows for insurers to know that if a particular choice is being made, that it actually has passed muster. And this actually does help the insurers also, factor in their reimbursement for a particular drug therapy. Now, I want to show you some of the studies that actually led, and I can't go through all the studies today, but I want to show you some of the studies that actually led to the inclusion of these recommendations. I want to acknowledge here Matthias Rummel from Germany, because he did this very large study as part of the German STILL group. It's a big lymphoma group in Germany, where they compared bendamustine and rituximab to, at that time, which was the standard in lymphomas, which was CHOP and Rituxan. This was a fairly toxic therapy that was being used, and they wanted to see if bendamustine did better or as good as CHOP Rituxan. So this was what we call a non-inferiority study. It was just meant to really see if bendamustine Rituxan was as good as CHOP Rituxan, which was a very toxic therapy. And 549 patients were included. Now, these were patients with all kinds of lymphomas, but among them were patients with Waldenstrom. And basically, you got 6 cycles of bendamustine and Rituxan, or you got 6 cycles of CHOP plus rituximab. And at the end of the day, what we learned from these studies, which included 40 Waldenstrom patients, was that the patients that got bendamustine and Rituxan among the Waldenstrom's treated patients, and again, this is Frontline, actually did better from a progression-free survival perspective, meaning that you can see here the chart, how much longer somebody stayed in remission compared to somebody who got CHOP Rituxan. And there was also more toxicity associated with CHOP Rituxan, which is why this study helped support the inclusion of bendamustine and rituximab to the NCCN guidelines. And this is the INNOVATE study. I alluded to this earlier, which was a randomized study, again, large for Waldenstrom's, where 150 patients were randomized to either get ibrutinib and Rituxan or got placebo plus Rituxan. This was a large study. Panos Dimopoulos in Greece and Christian Buski in Germany led this effort. And these were, patients that actually had substantial disease, as you can see here in the baseline, characteristics. The average IgM was about 3,300. and the average bone marrow infiltration was about 75%. And what did we learn here? Well, we learned that if you got ibrutinib and Rituxan, you actually did better than if you got a placebo plus Rituxan. This was an important study because in the community, many people tend to get Rituxan as their first line of therapy. So it did prove that if you added ibrutinib to Rituxan, you could see a better outcome in terms of not only responses, but also progression-free survival, the time that somebody stays in remission, which was superior for ibrutinib and Rituxan compared to placebo plus Rituxan. And this is, I think, also why Innovate supported the approval of ibrutinib, not only in the United States, but also in Europe and elsewhere. Now, I also want to talk about zanubrutinib. This was an effort that initially started with Judy Trotman in Australia, just an absolutely wonderful, wonderful individual who has done, a lot of work for Waldenstrom patients. And this was the initial phase 2 study in treatment-naive and previously treated patients. Now, what was learned in this study was actually quite interesting. They first figured out whether or not to use zanubrutinib once daily at 320 once daily or 160 twice daily. And what they actually saw was very similar responses, but slightly more deeper responses associated with giving the drug twice daily. In fact, in this phase 2 experience, 42% of the patients had at least a very good partial response. This was true of both patients who were seeing zanubrutinib for the first time or had already been previously treated. And so this actually then supported the other important study, which was the big news in the last year, and that was the ASPEN study, which was a phase 3 study. This was led by Constantine Tam, also from Australia, that pitted zanubrutinib against ibrutinib for MYD88 mutated patients. In this study design, zanubrutinib was given twice daily, and ibrutinib was given once daily. And there was a separate cohort of people that had no MYD88 mutation that got zanubrutinib alone. Responses were seen, as I earlier showed you, among this patient population. But this pitting of one drug against another was quite interesting, one BTK inhibitor against another. You can see that this was, also a very good study in terms of, numerical entry. There were 200 patients, 201 to be precise, that were randomized to ibrutinib or zanubrutinib. And again, these patients, were individuals that actually had, significant disease. Both treatment-naive and previously treated patients were included. Now, numerically, the number of major responses were similar, but there were slightly more very good partial responses associated with zanubrutinib in the study. This did not reach statistical significance at the time that the data cutoff was contemplated, but nonetheless did show that zanubrutinib produced as many, if not more, of these deeper responses. But the big news here was the side effect profile. There were fewer atrial fibrillation events. This is cardiac arrhythmia. Fewer diarrhea events, fewer bleeding events associated with zanubrutinib. But there was slightly more neutropenia. This is when the white blood count goes down. More usage of the growth enhancing hormone GCSF to keep that white blood count higher, but no difference in infection rate between ibrutinib as well as zanubrutinib, and that's important to keep in mind. So at the end of the day, zanubrutinib, was shown to produce a slightly different side effect profile with less atrial fibrillation, less diarrhea, less bleeding, even less hypertension, and so this, supported the addition of zanubrutinib to NCCN guidelines. And we also saw among cohort 2, which were the MYD88 wild-type patients, very high rates of major responses, and also the fact that many of these patients continue to have ongoing responses. So important to keep in mind that very good data, once again, supported not only the inclusion of zanubrutinib to the NCCN guidelines as a preferred therapy, but also because of the randomized nature of the study, a Category 1 recommendation. Now, again, I don't have time to go through all the therapies for previously treated patients, but I do want to talk about acalabrutinib that was recently also added to the NCCN guidelines But because most of the data generated here was among previously treated patients, this was only included as an other recommended regimen to previously treated patients. The preferred regimens, by the way, you'll see, are essentially the same ones as we saw in upfront patients, and that's because they included patients with both previously treated and untreated disease. So these are the characteristics of the patients included on the acalabrutinib study. Again, this is a different BTK inhibitor. This did show very high rates of responses. In fact, this drug also is given twice daily at 100 milligrams twice daily, but the response rates were the same as we saw with zanubrutinib and with ibrutinib, and even the progression-free survival with the just slightly over 2-year follow-up was the same. Slightly different side effect profile. They also had a very low incidence of atrial fibrillation, but so did ibrutinib at the same juncture of time at 2 years. Over time, there were more events of atrial fibrillation. So we'll see what happens with acalabrutinib. And what you see is headaches, especially in the first few months of treatment, occur with acalabrutinib, and then these tend to abate. So it is important to keep in mind this also represents a very exciting option for the treatment of Waldenstrom's, but by NCCN guidance in previously treated settings. Now, NCCN also makes a commentary around what do you do with somebody once they've already responded. And this really refers primarily to people who have gotten what we call chemoimmunotherapy, who got rituximab-based therapy. It could be with bendamustine, with cyclophosphamide, or with other combinations. And this was also an interesting, consideration because in the past, the use of maintenance rituximab was considered, particularly for patients that had a partial response or a minor response to therapy. In the case of somebody who got a CR, observation was being considered. But we did learn, because of Matthias Rummel's very important study from the Still group that was presented at the ASH meeting, that if you had somebody who got bendamustine and Rituxan and who achieved at least a major response, and then were randomized to either watch and wait or to get maintenance rituximab, in this case, 1 infusion every 2 months for 2 years, that even though you did not see a difference for all patients in terms of progression-free survival between these two groups, those individuals that were 65 years or over actually did show a difference. And so I think as we go ahead, there is some rethink that needs to be done on the current NCCN guidelines and perhaps fine-tuning the recommendations around maintenance rituximab for those individuals that are over 65 years in age and over. And again, what I'd like to say is it's in the guidelines, but the actual implementation of this should be something that should be discussed between you and your doctor, again, based on the science that's currently in hand. In a couple of words, I just want to talk about the IgM-MGUS and IgM-related disorders. These may be terms that you may have learned more about during this meeting, but I just want to clarify them because these also now have made NCCN guidance as well. So IgM-MGUS, again, described by Bob Kyle, means that you have somebody who presents who has the IgM monoclonal protein in their blood. So you do pick up the M spike or IgM M spike. But based on the workshop criteria, when you do a bone marrow, you don't see evidence of disease, and the patient is asymptomatic, has no symptoms related to the IgM being produced. And so these are called MGUS patients, monoclonal gammopathy of unknown significance, meaning we don't know what this really means for a particular patient. The conversion rate is about 2% per year for these individuals who have the IgM-MGUS, slightly higher if MYD88 is detected, as we saw from some of the data that I showed you earlier. Now, somebody who has IgM-related disorders, this means they have the monoclonal protein, they have no bone marrow involvement, but the IgM is causing trouble. It can be causing neuropathy or other problems associated with IgM. And then there's the category of asymptomatic Waldenstrom's, and there are many such patients who actually have the monoclonal protein for IgM, have bone marrow involvement but are asymptomatic, and these would be people that you would normally just watch and wait, whereas individuals that are symptomatic are individuals that have the IgM monoclonal protein, have bone marrow involvement, and are symptomatic. They could be symptomatic from the IgM protein or from the disease itself. And so keep this in mind, because this does separate out these different clusters. And important to keep in mind that the IgM can cause havoc, as well as the light chains. Light chains are part of the protein that accompanies usually the IgM. These can cause symptoms from, if you have too much IgM, you can get hyperviscosity. Sometimes the IgM under colder conditions can precipitate out and cause Raynaud-like phenomenon. I think many of you are aware that the IgM can also cause neuropathy. You do know that sometimes the IgM can bind red blood cells and cause them to hemolyze or to break apart. And many times these proteins, both IgM and the light chains, can get into organs and cause all kinds of havoc, including atrial fibrillation if they get into the heart. This is typically what we call amyloid, which is a derivative of the light chains being produced in Waldenstrom patients. And so now there is NCCN guidance. In general, there is an advocacy to treat patients who do have problems associated with the monoclonal protein or the light chain, irrespective of whether or not they have the Waldenstrom's diagnosis. And so again, without getting into too much detail today, because of our limited time, it's important just to keep in mind that we now have guidance. Sometimes the light chains can also cause renal failure. We call that a monoclonal gammopathy of renal significance. So there's also guidance in terms of how to manage such patients, even when they don't have the full Waldenstrom criteria. As I alluded to at the beginning of my talk, when you look at NCCN, they don't really give you particular guidance as to how to employ therapy for a particular individual. And I just want to refer you to a couple of guidelines that might be helpful to you and your physicians. The first here that I just want to refer to is the Mayo guidelines, which is based on consensus within the Mayo itself. These guidelines have been developed for a number of diseases. And for newly diagnosed Waldenstrom's, it's important to keep in mind that these guidelines go by how impacted somebody is by disease, meaning that if you are lightly impacted, you have anemia, you have some minor symptoms of the disease, such as cryoglobulinemia, or the cold agglutinins are causing hemolysis, or you have IgM-related neuropathy, then the advocacy there is to consider single-agent rituximab. Whereas in individuals that have, more involved disease, bulky disease, have more profound cytopenias, meaning anemia, as well as the platelet count being much lower, and having, signs of hyperviscosity, let's say, this would actually, entail more aggressive therapy. And of course, if somebody's having hyperviscosity, you would plasmapherese them first, get that IgM down, and get them out of harm's way. And in this case, for the more involved patient, the recommendation here is to go with bendamustine-based therapy. And you would introduce the Rituxan only if, somebody is out of hyperviscosity, because the IgM can go up abruptly with rituximab. And in the case of somebody who's younger, maybe to even consider taking stem cells and harvesting them for a possible auto transplant in the future. So again, this gives you some guidance, both in the frontline setting, but also in the relapse refractory setting, where if somebody, for instance, did well with their therapy for about 3 years or more, then you can recycle the previous therapy, or you can consider, in the alternative, using a BTK inhibitor or other options like bortezomib-based therapy, and then consider maybe an auto transplant. So this is a little bit more walking somebody through particular options based on the involvement of disease. Now, at our institution, we tend to use more of a genomic-based approach, and this gives you at least some other notion of how one can manage patients based on genomics. So you don't just get a menu, but you also now get to look at somebody's genomics in terms of making an informed decision. And these were published last year in the Journal of Clinical Oncology. And here, if you have only the MYD88 mutation, when you're first presenting with Waldenstrom's, to prioritize a BTK inhibitor as monotherapy, meaning by itself. And then alternatives, in the event that somebody has bulky disease, maybe prioritizing bendamustine, or if somebody has amyloid protein, prioritizing a proteasome inhibitor-based therapy. If the patient is double mutated, to consider whether or not somebody needs a rapid response. And if they need a rapid response, because as I told you earlier, those people that have the nonsense CXCR4 mutations might have very high IgM levels and symptomatic hyperviscosity, that you take care of that immediate problem with plasmapheresis. But here you don't consider BTK inhibitor because it may take too long. You consider bendamustine or proteasome inhibitor-based therapy. And if you have somebody who's double mutated but doesn't require an immediate response, to consider in this case a BTK inhibitor plus maybe rituximab in order to shorten the time to get to a response. And the real issue these days is what do we do with people who don't have the MYD88 mutation? In this guidance that was published last year, we advocated for bendamustine-based therapy or proteasome inhibitor-based therapy, but now with the data with zanubrutinib, being also an option in these patients, one can consider that as well. And among previously treated patients, important to keep in mind that a similar algorithm can be considered, but now because of the data that you've already heard from Dr. Castillo, that other options, even after BTK inhibitors, are growing. And among these is venetoclax, which is very effective even in patients who have seen a previously BTK inhibitor. And this study was just accepted for publication in the Journal of Clinical Oncology, one of our most prestigious journals. And so I assume that as we go forward, we're going to learn more. We're going to have newer treatment approaches. We're excited that next year's international workshop on Waldenstrom's will be taking place in Madrid. This under the guidance of our two wonderful colleagues in Spain, who've made tremendous contributions to Waldenstrom, Dr. Ramon Garcia Sanz and Dr. Jesus San Miguel. And so, stay tuned. I think more adoptions around the workup as well as treatment of Waldenstrom's will be forthcoming because of this meeting. And of course, I'm very happy to entertain any and all questions, and very excited by all this progress. And it was very nice to have this opportunity to be able to share all this with you today. And with that, I will stop and pause at this time. Thank you very much.